So in thinking about this meeting, I'm not going to talk about specific research studies and trial results, but float some ideas and try to justify them for SHAPE. And I think the first point is that there is an unmet clinical need that SHAPE can fill. So part of what we're doing is what's the role of SHAPE in the future, and clinical trial we're going to talk about in a few minutes. And is there a need? And let's see if we can expand this into a bigger mode. Oh, thank you. So some thoughts are that SHAPE should consider expanding its activities beyond non-invasive imaging, and so that's what we mentioned when we made our introductions. That it could embrace cutting-edge atherosclerosis issues ahead of the guidelines. So I submit that there's a need for something before the guidelines. There's a lot of clinical need out there, people want advice from experts, and the guidelines, I think, we all agree are 10, 20 years behind what's actually going on. So perhaps that's a role that SHAPE could play. It should consider having more active public role. So part of the issue is fundraising and raising the awareness of SHAPE, and this can be done in a variety of ways. Kiwanis Club lectures, we've all given tons of those, but somehow enhance the image of SHAPE, getting closer to a national and international organization. We have a stable of experts right here that could provide and do a lot of that. So those are some of the initial concepts. Can we click on the next slide? So if you read the upper corner of this agenda sheet there, it says mission statement, eradicating heart disease. So it doesn't say diagnosing heart disease, it says eradicating heart disease. And the name of SHAPE is Society for Heart Attack Prevention and Eradication. So I think that's part of our discussion here and previously that we sort of minimalized. It's been focused on the diagnostic aspects, and I'd like to suggest we focus more on the other part of this, which is prevention and eradication. So we can help keep ahead of the times by addressing some of these controversial issues. I've just listed a few here. And obviously, the idea we've talked about years before here is combining non-invasive imaging with the power of metabolic, metabolomics, proteomics, genomics, so that we have a complete picture of not only diagnosis, but prevention. One of the controversies, just as a suggestion, is this whole fish oil thing, which everybody's familiar with, and that's controversial, but there's a lot of good data about measuring blood levels. And that was a publication we had in Superko about a year ago. And we actually had an American Heart Association session on this with experts from around the world. So information like that could be promulgated by SHAPE way ahead of other organizations. I'm going to focus in just a minute on family heart disease and firefighters, but I put those up there because I think SHAPE could focus on a very narrow area and pick whatever area you want, but do something to accomplish something good for the public and a public image. And family heart disease clinics might fit right in there. It's already, lots of stuff is published in non-invasive imaging and genetics, and that seems like a no-brainer that we'll get to. Could we click to the next one? So this is a paper that's published online and will be in Superko on September 1st. And we've already seen one by Gabel, is that how you pronounce that last name? And so this is looking at the MESA data, and it's looking at a slightly modified way of calculating risk. So it's called CPCE. And they looked at individuals with risk less than 7.5%, therefore not, quote, statin eligible, unquote. And in that group, 57% of the events actually occurred in that group, according to that definition. And they looked at the recommendations that were in the ACC/AHA guidelines for possible other factors that would enhance risk classification, such as CAC scoring, family history, HSCRP, as you see there. And down at the bottom lower left, if you look at the relative risk of the CAC score, it's 4, which is nice and high, so that makes a lot of sense. But also family history, and the family history was simply, is there a family history? It wasn't premature, it wasn't less than 55. The question was simply, is there a family history? And that was equally powerful. So I think this is another nail in the coffin, or not nail in the coffin, But this is another piece of strong evidence that some other aspects enhance the ACC guidelines. And the ACC guidelines by themselves are inadequate. One of those things that enhances it is CAC scoring. The second thing that enhances it is a very simple question that doesn't cost any money at all, which is there a history of heart disease in your family? And then I was lucky enough to be asked to write an editorial on it, and those two things are in the papers downstairs if you want to get them.
Robert, since you
Yes.
wrote the editorial, I read this paper differently. My grid was, 57% of events were in that population that are not statin eligible according to me. But use of coronary calcium only improved, reclassified 6.8%.
Correct.
And when I did the math and I emailed David Merrin and Matt Udall, we had to screen 4,800 some people to reclassify 12 of them to high risk by coronary calcium. That's an awfully low yield and low cost
effectiveness.
You wrote an editorial. What's your thought on that?
Well, the cost effectiveness issue all depends on what it costs to do what you're doing. So for family history, the cost is zero. There's no cost to that at all. The cost to CAC scoring, and I sent around a memo and asked people this, is anywhere from $50 to $350. So, and CAC scoring could be even less than that.
Let's say it costs $20. Mm-hmm. If I screen 4,000 people to get 12 of them reclassified, just reclassified, not save their lives, reclassified, can I justify that math?
I don't think that's the math.
You
reclassify 57%. I don't
No.
see why. No, you're talking about events.
That's
Scorching events with reclassification.
Well, according to him, only 6.8% upward reclassification, which means we made them high risk. So 6.8% of the 4,000 is only 12 people. So we need to screen 4,000 people to get 12 of them reclassified to high risk, from this less than 7.5 to more than 7.5.
More, I think your math is wrong.
Yeah, I was going to say,
You have to classify 264 people out of 3,882. MESA without diabetes, not
In this less than 7.5% people.
Yes.
If
So
you
that's
screen-
10%.
So that would be 264 out of 3,882, which is 6.8%.
You're
Okay, so
reclassifying 264 people, not 12.
264 people out of 4,000,
No,
800.
that's percent.
3,800, right.
right? About 4,000 would be screened, 264
And 64
people would be reclassified, reclassified. Is that what you're saying?
Yes.
And so that really is our dilemma, is whether this is cost effective and how many of those people.
But we
But
already-
that's not events, Mort. That's just saying that to put them in the category that they think is correct. The Rose principle states that most events will always occur in the lowest risk population. So our goal is not to up-classify or down-classify, it's to properly identify who will have an event. So I don't care where CAC puts them in the ACCHA pooled cohort. I care who with a CAC score that's positive, do they have an event, and who with a CAC score of 0 doesn't have an event. So the endpoint is not reclassification, like this paper. The endpoint has to be proper, it has to be events.
Well, the events were also high. Of the total 156 events, 35 occurred in those that were up-classified, reclassified.
Right, but that means 65%
You
were
got-
not.
You got 13.2% event rate
Right,
versus.
so all I'm saying is that, let's say you do a calcium score in this group, and it doesn't quite hit 7.5%. According to the Framingham model, or this model, it hit 7.2%. But they have an event. I would say CAC is correct, even though Yeboah would say it missed the mark. So Yeboah's endpoint is who hits 7.5%. The right endpoint for an event trial is who actually has an event. So I don't want 35%. I don't want to identify 35% who were up-classified who had an event. I want to find the 100%, or as many of those 100 as I can, who had an event. And calcium does a much better job of identifying who has an event than up-classification. So I would say this is the wrong endpoint to power a study on, that's all. I'm not saying that this data is incorrect. I'm saying that I don't care if they hit 7.5 or 7.4, but rather did they have an MI or not.
Okay, I'll redo my math during the
Yeah.
time, but the point is that what they're claiming is the opposite of what your conclusion is. This paper saying that coronary calcium in this population is not doing much, even though the event in this population is significant. That's what their message is.
Well, I think also their message is some of the issues that the ACC guidelines suggested could improve the ACC guidelines are in fact correct. And so whether or not you pick family history or CAC scoring or genetics or whatever, there are issues that can improve the accuracy and ability of the ACC/AG guidelines to do what they're supposed to do. Whether or not it's 7.5 or 7 or 10 or whatever, and those are all, manipulations of the data. So my purpose is to show that. Now let's go on to the next slide. Yeah, no, we can go to the next one. I'll save some time here. So one of the things is genetics, and I think you've all seen this slide before. This is the 9P21 issue. Bob Roberts has done a ton of work on this. Those are all the studies. Everything's to the right of the line of unity. This simple single SNP is an incredibly powerful statistical marker of risk, and just click it once with a p-value of like 10 to the minus 60 or something. The relative enhanced risk is relatively small. It's like 1.3. There's a gene dose effect, so it's 1.6. So while it didn't happen due to chance, and it's very statistically true, the impact itself is relatively small. So what's gone on the past couple of years is a number of groups, including when I was at SLAIR, we're looking at groups of 20 SNPs, 25, 30 SNPs, and the idea at that time was you would modify which SNPs you use based on gender, for example, or ethnicity, because you kind of pick your favorite SNPs and then you put these panels together, and that's sort of where the field is going. So next slide. And this is Jessica's work. So this is very recent stuff, last month or so. And I think this paper's downstairs too. So Mort has tons of reprints downstairs for everybody. So this is a panel of 20, a cluster of 27, showing that it's used for predicting or identifying a subgroup that obtains more benefit from statin therapy from two studies, Jupiter and Ascot. So if we're planning a study in the future, it's going to use non-invasive imaging to identify individuals who are going to have an event, like Matt says. Tools like this, either on the front end to identify if the groups can be useful, or clearly at least to analyze the data retrospectively, are very powerful. Next slide. And the other important thing that is the cost effectiveness issue that Mort brought up. So back in 2001, when the race was on between Francis Collins and Craig Ventnor, the estimate to do the genome sequencing was $100 million. And because of technical improvements in the lab over the years, that's dropped tremendously. And yesterday I just reviewed a patient's whole genome scan that he got in Taiwan for $1,500. So when you think about the clinical trial and the cost doing any of these genetic tests is just plummeting. And I think could be very efficiently done, and you'd probably find partners that would be happy to work with you in this regard. So the cost of any of these tests is just plummeting right now. Next slide. So the two things I'd like people to consider if people agree that SHAPE should move into a more clinical area other than just diagnostics is family heart disease and firefighters. And family heart disease, I think, is sort of a no-brainer. This is something Brenda and I have done for 8 or 9 years back in Atlanta. There's a screaming clinical need for this. And when you do CAC scoring, for example, or carotid ultrasounds and find individuals with disease, because of the familial and genetic link, it only makes sense to start to identify first-degree relatives that might need your care. So in a clinical sense, this has been very well received, and it's something I think SHAPE could embrace, because SHAPE would have both the diagnostic imaging aspect and the therapeutic aspect. And the second thing is firefighters. In both of these, we use CAC scoring in everybody. And the firefighter study was a federal study that's also reprints downstairs. because firefighters have about 300% more heart disease than any other profession. And we did a federal study and found part of the reason why, and then started a national program of screening firefighters using CAC scoring and talking to different hospitals and groups to get the CAC score financially at a low enough level that firefighters can use it, and then along with some tests. So that's something else that SHAPE could consider embracing, is a national firefighter heart disease prevention program, which would fit right in with everything that SHAPE does. Next slide, which might be the last. So the last slide is some thoughts. Obviously, continue the efforts that we've talked about here today with the research, with non-invasive imaging, enhance the public image of SHAPE with its related activities, integrate SHAPE into coronary disease etiology and treatment, so that's diagnosis from a metabolic and genetic standpoint, and treatment to stay ahead of the curve, consider family heart disease clinic initiative, and consider a national firefighter heart disease prevention initiative. So that's all I have to say.
Thank you.